So welcome to Bill Mental Ultrasound Training Institute. Today we'll be taking a short, I will say, vlog about infertility ultrasound. Ultrasound in female infertility. We'll be taking a very short vlog of that. So I'm highlighting this that this is not a training course. Right now, what we are taking is not a training course, but a very short vlog. So let's start the ultrasound in infertility. Now, whenever we are inserting a probe or putting a probe onto the uterus, we are usually more concentrating on the ovaries. I mean, when we are inserting the probe for infertility scan, we are more concerned always about for the ovaries only. We want to see the dominant follicle, the rupture of the follicle, but equal important is endometrium. We are paying less attention to endometrium. We have to pay equal attention to the endometrium also. So point number first is that not always confined on to the ovaries for this follicle only when we are taking these infertility scans, but equal important is the endometrium also. So have a look on endometrium also, because this is equally important. As is important the follicle, so is the endometrium also important. Now when we are taking these follicular studies or the infertility scan, what we are choosing, we are choosing first a probe. Now which probe to choose first, that is also important. The transabdominal ultrasound is having a lesser resolution, but here the scanning field is wide. So for a transabdominal, we are having a wide field, but resolution is less. Whereas in case of a transvaginal ultrasound, we do have an increased resolution, but the scanning field is very narrow over there. So we have to at times choose for a narrow, but at times we need a wide field. So we have to see whether we need a wide field or a narrow field. Now, when we are talking of the infertility scan, what we have to see in the uterus is that whether there are any fibroids or there is an adenomyotic patch, I mean the adenomyosis, whether there is endometriosis, maybe that you are dealing with a polyp, so we have to see for any polyp over there, maybe a dermoid is over there, then the endometrial hyperplasia. Now see, this endometrial hyperplasia means that the endometrium is very thick, so don't get happy with the thick endometrium. This is the point over here. If endometrium has crossed 14 mm, that can be a case of endometrial hyperplasia. So that can be underlying cause of an infertility scan. So see for any PCODs, pelvic inflammatory disease, endometritis. The point here is that if you will keep this checklist in your mind, most of the times you will get something from an infertility scan. Don't always see to onto the follicles only. Now, when you are seeing to the ovaries, maybe that there is a cyst over there, these ovarian cysts. Now, in these ovarian cysts, what we have to first see is that whether we are dealing with a cyst which is arising from an ovary or extra ovarian, that is ovarian or non-ovarian origin. So we have to first see to the origin. Then we have to see for the USG pattern. By this USG pattern, we will be able to comment whether I am dealing with a simple cyst, hemorrhagic cyst, endometrioma, maybe a teratoma over there, or maybe that there is a possibility of a malignancy also. So then we have to decide whether the malignancy is having a low risk or high risk. So the point here is that sometimes we are ignoring these small cysts if they are simple.
and sometimes we have to evaluate with MR, and we have to maybe go for a surgery also. And many a times we have to keep a follow-up. So first of all, see whether you are dealing with an ovarian or a non-ovarian, then see for the USG pattern, and then decide whether I am dealing with a low risk or a high risk. I mean the malignancy. Now, the most common cause of the infertility. Now, from this uterus, what I will be expecting to see in a uterus in an infertility case, I mean, maybe that there is a congenital abnormality, maybe that there is an infection, maybe that there is a uterine synechia, maybe that there is any focal lesion, maybe that there is a cervical stenosis, and maybe there is a decrease thickness and vascularity of the endometrium, I mean, which we will discuss later on. Now, from ovary, maybe that there is a follicular or ovarian abnormality, stromal vascularity, we have to see. Endometritis, we have endometriosis, we have to see. From the tubes, we have to see for any obstruction, for any infection. From cervix, we can see maybe that there is a maybe a mass in the cervix. The point here is that we have to search for the uterine cause. We have to search for the ovarian cause. We have to see for any tubal cause, and maybe that there is a cervical factor. The point here is that we have to keep a checklist in our mind. Then only complete is the infertility scan. So again, repeating, not only follicles always. So we have to equally see to the uterus. Now, in this endometrium, we are seeing the triple line endometrium. What this triple line endometrium is all about. If I will put an A over here, B over here, and C in between, the point here is that this is the A line. This I am labeling it as B. The in between is C. So if I will say that this C is a tunica functionalis, will I be wrong? No. So this is tunica functionalis. So the complete thickness, this thickness of endometrium is attributed to the C. So the tunica functionalis is actually defining the endometrial thickness. So it is again because of this tunica functionalis, the C that I am having triple line endometrium. So have a clear understanding of these triple lines and the endometrial patterns, and see where this tunica functionalis is, and see the importance of the tunica functionalis. We have to see when we will be putting a color over here, we will be seeing the vascularity, whether it is touching this line or crossing the border, which we will come in later slides. Now, right after menses, you know that the endometrium is thin in proliferatory phase. I will be seeing a triple line endometrium. As I am moving from the proliferatory to luteal phase, then the endometrium is getting thicker, but it is getting hyperechoic as well. Now, how much should be the endometrium? Favorable will be 8 to 13. So in between 8 to 13, I will say, thank God it is in this bracket because this is favorable. And less than 6 and more than 15 are problematic. So this is what I started. In start, I said that I should not get happy with a thick endometrium. So, and a thin endometrium, of course, we all know. So the thicker the endometrium, if it is more thicker, then that can be also a factor which has led to an infertility. Now, we have to grade the endometrium. When we are putting a color, this is very important. When we are putting a color onto this endometrium, we have to see where these vessels are. Are they just touching this line, crossing this line, or touching the inner line? That way, I will be grading it in zone 1 to zone 4. Now, what is zone 1? Zone 1 is that whenever I'm having an endometrium, this vascularity which is in surrounding myometrium, which is surrounding myometrium, not going into the endometrium, that is zone 1. Now, zone 2 is that this vascularity is touching the hyperechoic endometrial edge. That is zone second. Zone third is that when it is going into the endometrial hypoechoic zone, that is where in tunica functionalis. So if the vessels are in tunica functionalis, that is zone third. Now, what is zone fourth? Zone fourth is when it is not only penetrating, but it is piercing and going into there and touching the central line. The central line is actually the uterine, I will say it is the collapsed uterine cavity. So the point is I have to see for these vascularities. I have to label the zone of the vascularity. Because, for example, if there will be an blastocyst, which has dropped for implantation in the endometrial cavity, and I am having a zone 1 vascularity, the blastocyst will not make a connection with the vessels and will be thrown out. But if the blastocyst will drop into this endometrial cavity, we are having many vessels which are touching the zone, this zone 4, which are touching into this central line, it will easily get implanted. So see the importance of the vascularity. So you have to see for this vascularity. Maybe that your patient is having a zone 1 and you are only seeing for these follicles. Follicle is increasing in size, releasing the ova, everything is going smoothly, but you are not seeing to these zones. And whenever the blastocyst is dropping into the endometrial cavity for the implantation, the vascularity is not appropriate. I will say it is zone 1 or maybe zone 2. The blastocyst is not able to make a connection and hence it will be thrown out. Now, I am putting biophysical score of uterus. Yes, repeating, biophysical score of uterus, not of a fetus, but a uterus. Now, in biophysical score of uterus, what we have to see for certain points. And we will be adding these points like we are adding in biophysical score of fetus. First is the endometrial thickness. If it is less than 7, then 0. If it is in between 7 and 9, 2. If it is in between 10 and 12, 14, straightway 3. But if it is more than 14, 1 only. The point here is that, the point here is that the increase into the endometrial cavity, I mean the thickness, is dropping the score. So don't get happy with that thickened endometrium. 10 is the layering. If we are having no layering, then 0, hazy 1, distinct 3. So we have to see for these layering. If I am having a triple layering, not hazy but distinct triple layering, I will be giving 3 points. Endometrial contractions. Endometrial contractions are seen in a scenario. And if contractions are less than 3 in 2 minutes, 0. If there are 3 contractions in 2 minutes, straightforward 3 points. Then the myometrial echogenicity. If myometrial echogenicity is coarse or heterogeneous, only 1. And if it is homogeneous only, then I will be giving 2. Then I will be putting your favorite uterine artery Doppler. So whenever I put a Doppler on the uterine artery, I will see for the pulse style index. And if pulse style index is more than 3, then 0. And if pulse style index is in between 2.5 to 2.99, then 1. The further drop in the pulse style index, which means I am having a low resistance over here, 2.2 to 2.49, I am straightway giving 2 points. And if I am having a pulse style index of less than 2.19, then again 2. The point here is that dropping pulse style index is increasing the score. Then, the important is, everything is important over here, but I will highlight for today this endometrial endometrial blood zone. If in zone 3, you know now why in zone 3. If in zone 3, what is that? That is hypoechoic inner layer of the endometrium. Then if it is absent there, 0. And if it is present, 2. And if it is abundant, straight with 5. So the point here is that I have to see whether this zone 3 is having vascularity or not. And if it is abundant over there, then 5 points straight away. Then myometrial blood flow internal to arcuate vessels, absent 0, present 2. The point here is that where is your favorite follicle? I am not saying follicle is not important. I am saying that after follicle, you have to see whether I am having a fertile uterus or not. I don't want you to keep a calculator in your hand and keep on adding these points. No, that's not the point. But the important point is that I haven't had to see for the endometrial thickness, and I should not get happy with that thick endometrium. I have to see for the distinct layering also. By layering, I mean that I should not have a hazy trilaminar. I should have a distinct trilaminar pattern. So, have a look on endometrial thickness, see for the endometrial layering, see for the myometrial contraction, see for the myometrial echogenicity itself. Because if it is heterogeneous, there will be a drop. And if it is homogeneous, then I will give you the sufficient marks. I mean the points. Then put a Doppler and see for any decrease in the PI. More decrease, more the points. And see for this vascularity, which is very important. And you can see the myometrial blood flow internal to the arcuate vessels also. So this is what you have to see in uterus in an infertility scan. There had been a study. This is a very big, long study. I'm giving you the moral of this study. The moral of this study was that whenever there was a perfect score of 20 has been associated with the consumption of 100%. The score of 17 to 90 was associated with the consumption of 80%. The score of 14 to 16 have a 60% chance, while the score of 13 or less have resulted in no pregnancy in that study. So the point here is that if there is a drop in the score, the patient will never conceive. And you will be always seeing onto these follicles and follicles only. So, the point is that your score should not be less than 13. Because if it is less than 13, then the study showed me the result of 0 conception. So, take home message is that we have to scan the uterus very, very properly in an infertility patient. We have to see for the biophysical scoring of uterus. We have to see for these endometrial thickness, endometrial layering, myometrial contractions, myometrial echogenicity, uterine artery Doppler, and endometrial blood flow in which zone. Then you can put a Doppler to see the vascularity. Label the zone of vascularity. This is very, very important. So, this was all about, not I will say all about, this was a very short vlog of infertility scan. I am again repeating in and this is a short vlog for Facebook, YouTube, and other social platforms. This is not a course right now, what we have conducted. For a course, you can contact our helpline. We are having a detailed server-based courses. So we'll be seeing you very soon with upcoming blogs also. So if you are interested for any, online server-based course, you can contact our helpline number. So this is our helpline number 4 times 9 34 72 42. Or you can visit our website, which is www.birmed.net. So do stay connected with us via the social media platforms. Thank you very much. God bless all.